nice to have it zeroed. All right. So moving on, we are going to move to the worms. Don't worry about this slide. This is just to give you a little overview about the next couple of classes that we're going to talk about. Okay, these parasites are broken up into two specific groups, the protozoas and the helminths. And these helminths are broken up even further into that, into platyhelminths and nematodes. As you can see, each one has its own little thing. We're going to start off with the helminths when we start our first little class. And it'll be the flatworms, it'll be the cestodes and the trematodes, so the tapeworms and flukes. And then we'll talk about the nematodes, which will be the roundworms. So, big thing that I want to make sure that you guys get here is the helminths. Okay, any of those worms on the left side, on the left side of the screen, will stimulate a eosinophil reaction in the body. Generally, as it migrates through the body, it'll cause eosinophils to go up. So when we're talking, what do I look for? What you're going to look for in these will be eosinophilia. Okay. What happens is it stimulates your T helper 2 cells, and then your T helper 2 cells stimulate interleukin 5, interleukin 4, interleukin 13, and then all those other guys go and do things. Now the reason why I bring this up is because unlike everything else that we talked about, these things would come, right? Your white blood cells would come, your macrophages would come, it would kill everything, right? In this case, the eosinophils cannot kill the parasite. What they do, on the other hand, is that they attach the IgE to the surface of the parasite, and they release toxic granules that dissolve the outer protein layer of that parasite. So it's kind of like ripping your face off, or ripping your skin off is what they're doing to the parasite, because they cannot phagocytize it. They cannot kill it. So the only way to do it is this way, to attach the outer layer of their protein and destroy it by releasing toxic granules. That's how that part works. All right? So the cool stuff about some of these, we'll talk about the protozoa ones. They eat 3 different ways. They either phagocytize their food, which means that they eat, right? They eat the cells that they encounter for food. They penocytize their food, which means they abut it and they just drink it. Or they just absorb nutrients like the cestodes. They just hang out and they absorb everything that you eat, and they just absorb it, stealing it from you. Okay? Then we move on to the cestodes. The cestodes are tapeworms. They don't have a digestive system at all. Okay? They absorb the pre-digested food that you eat. They have what we call microtriches. So the microtriches are basically little hair follicles across their entire body to increase their surface. So as you eat, they absorb more because they have a larger body surface. Now we've got the trematodes. Those are your flatworms. They have a simple digestive system. They have a mouth, a pharynx, and a gut, but no anus. So where do you think everything comes out of? Back out your mouth, right? All right, so they eat their mouth and it comes back out their mouth. Okay, that's the way they work. Okay, and then ultimately we've got the nematodes. They actually do have a complete digestive tract, mouth, gut, anus. So remember, all these things are eating, so they are releasing toxins and junk into your system, okay? Depending upon where they hang out. All right. Questions? All right. We're going to start off with cestodes. There you go, back of intestinal tract, and instead of absorb, are able to absorb the nutrients through their integument, which is the outside portion of the tapeworm. Okay. They have no mouth or digestive tract. So if you look at this area right here, if you look at the picture, if you guys can you guys see that pointer? All right, if you look at that little area there, that is what we call the scolex. That is basically their head. So one way to tell the difference between a lot of these tapeworms is just to take a look at the scolex, if you actually get one out. Right? That's one way. Another way would be looking at the eggs. But what they do is, with the scolex, they attach to your intestinal lining, okay? And then they just hang out there, and as you eat and other nutrients come through, they just absorb it. If you can see all these little rectangular areas there, those are what we call protoglids, or prolatids. Inside of those things, they break off, there's eggs in there. As they break off, the eggs scatter out, or they will go out in your poop. And then when you do your O&P, you'll see them in your O&P. All right? That's how these little guys work. Here are the ones that we're going to cover. 1, 2, 3, 4, 5. 3 basic worms with 4 different scenarios for different ones. So before we start here, I want to point out right here this pork tapeworm, Tinea solium, the sun pig, right? Sol, sun, pig is pork, right? This cysticercosis is an offshoot of Tinea solium. So we're going to do 2 different things with Tinea solium. Okay? And when we get there, we'll break it out. I just want to make sure that you guys understand. Those are 2 different presentations that we're going to see. Okay? So I'm going to lopiasis. This is Nana, dwarf tapeworm. Okay, 15 to 40 millimeters. That's about 0.6 to 1.5 inches in length. Okay, so they're very tiny. Okay, so you're going to have hundreds and thousands of these in your gut. They sit in the rugae and in your intestinal lining. They just attach there, and they just absorb all the food that you eat. Okay. They're worldwide, most common cause of all cystode infections worldwide. All right, so if you had to pick one, there you go, most common. The other one, the diminuta, is less common for humans. They usually like to infect insects, but we also need to understand, right? Number one, other cultures, right? Other cultures eat insects, 1. 2, if you actually look at, I believe the CDC, they'll tell you that we, in general, eat about 1 to 2 pounds of insects a year, haphazardly, in our foods, or if you actually eat the insect itself. Now, why is that the case? So if you look at the Food and Drug Administration, they will tell you that they are allowed to have certain amounts of insect parts in some of the food that comes out to you. So it is kind of important to know some of these things. These guys usually live about 4 to 6 weeks. So not extremely long, but they do have, excuse me, they do make a lot of eggs. Okay, so a little path. We usually ingest the eggs, right? Or either contaminated food, water, or poor hand hygiene. Okay? And for all of these, it will be poor hand hygiene. If you have poor hand hygiene with these, you can, what we call, auto-inoculate yourself. So if whomever has it doesn't wash their hands, or you have it and you don't wash your hands, even though you've been treated, but you still have eggs in your stool, you may touch food, touch your mouth, and then give it to yourself again. All right. So this is transmitted fecal oral. It goes down into your lamina propria, that is one of those layers of your small intestine. It attaches to the epithelium, and it just hangs out there. It just hangs out. That's all it does. Okay. And there it tells you corticoids are generated as it continues to feed off of you. One of the things that we should take into account, a lot of times, especially at the very beginning, we're asymptomatic. We're not going to realize any difference. Okay? And there's a lot of what ifs here, right? Especially for kids, little kids versus adults versus the elderly. Until we have a worm burden, and what that means is that there's so many worms in your gut that it's causing you either some physical symptoms or some actual symptoms, or it's stealing so much nutrition from you, you really may not get any symptoms. Right. So things to keep in mind. Here's so these are not going to be testable. I'm not going to test you on these life cycles. All right. There's a sigh of relief. So we poop this stuff out, okay? It either comes out, it gets eaten by a rodent, an insect, and then a rodent eats the insect, or we eat it, right? Be it contaminated food or water. Goes through our digestive tract. This is the way their skull looks. This is what their head looks like. It's a lot different than some of the other ones. That attaches to your intestinal lining, and then they start growing. All the little protoglids start breaking off. And then the eggs can either get stuck within your intestinal tract and hatch and create more, or they can get released into your poop and out the body so they can go and affect other people. All right? That's generally what happens. Try to keep it easy. Right? So there's the vast majority of us will be asymptomatic. Most healthy people can usually deal with these guys. And a lot of times they're only last for 4 to 6 weeks, which means they're going to eventually die. Hopefully, our body pushes it all out so that they don't stick around and we don't get more eggs in our body. And or we don't inoculate, self-inoculate or auto-inoculate ourselves, which means regardless of your body taking care of it, you're still giving it more eggs for it to continue to grow. Here's a couple of the symptoms that you're going to get. That restless and irritability. It's probably due to the abdominal pain and malnutrition that you may end up having if you get enough of a worm burden that it starts causing you symptoms, right? The nutrition deficiencies. Right? So because it's hanging out there, it's going to absorb as much stuff as it possibly can. But until you get enough, it's not going to affect you, which is why a lot of people are generally asymptomatic when they first get it. So remember, worm burden is what's going to determine how bad or what kind of symptoms you have. But remember, little kids are going to be affected a lot faster than we are, right? Because they don't have that resiliency that we have. Their gut's not as big as ours. And then remember, the older population, they usually present a little bit different. They also have nutritional issues. They don't eat as much as we do, so they may present a little bit differently than we do. So here's a whole bunch of the symptoms that we may get once we become symptomatic. Now, the diarrhea may be from mechanical irritation, because now we start to get a whole bunch of them. If we get a whole bunch of them and they all start swarming in your gut, they're going to make your intestinal tract move, right? And if it starts moving too fast, it's going to try to push everything out faster. So you may end up with some diarrhea. All right. You're going to have that, what is it, enopuritis. You may have that enopuritis for a couple of different reasons. Right? The little protoglids are rectangular. Right? So they may go, and as they come out, they may get stuck in your rectum. Right? And because they're in your rectum, they may cause you itchiness. So, reasons why. That restless sleep may be from abdominal discomfort, depending upon how much you have. It may even be from the nutrition malabsorption that you have that's just not letting you sleep. Or, if you actually know you have worms, it's going to cause you a psychological effect, right? And you're going to be itching and scratching everywhere. It's like, God, I got worms, right? So remember, there is also a psychological component to some of this stuff. Here's some rare symptoms that you may get. These will usually be caused when you have overburden. When you have too many, is usually when you get this, and that's really the key here for the more rare symptoms. Okay. Then nausea, vomiting, maybe for mechanical irritation or malabsorption, fluid imbalance. Remember, these guys are eating, so they're releasing waste into your system as well. Right? All of these are releasing toxins or waste back into your system. So it's also going to cause irritation into your body. Maybe, depending upon how many you have in your system, it'll cause toxemia. Right? So physical examination typically is unrevealing unless you have worm burden. If you have an worm burden, your belly may be a little bit distended or your belly may be a little bit tender. Right? But otherwise, you usually don't really see much physically. So, with this one specifically, you may have mild eosinophilia. This guy generally hangs out in your intestinal tract. That's it. That's where he hangs out. Everybody likes to have a hangout spot. This guy hangs out in your intestinal tract. Because it only hangs out in your intestinal tract is usually free of your body's reactions, right? So you're not going to get a whole bunch of eosinophilia. If you do start getting a lot of it, and it does start digging into your mucosal lining of your intestinal tract, right, like in the rare symptoms, then you will start getting some eosinophilia reaction. Right? But otherwise, it may be mild eosinophilia. And what do you look for? You do an O&P, and you look for the eggs. That's really what you're going to do. You'll identify the non-eggs and the stool. Now, with that being said, you may not always capture the eggs in the stool, so you may have to do repeat. And a lot of times, it's usually 2 to 3 times, you'll have to repeat those stool samples to see if you can catch it. Okay, treatment, positive quantum. That's support therapy. That's it. All right. There is a recommendation. Hey, 2 to 3 months later, after you're done treating, have them come back and do another stool sample to make sure that they're all gone. Right? And the reason why we do that, remember, is for the auto inoculation part. If you did something to yourself after you may have given it to yourself, it may come right back. Cyaniasis. Okay, so here we're going to talk about Solium, Tapeworm, Saginatum, angry beef. Okay, Taenia saginatum. Those species are worldwide. Taenia solium prevalent in poor countries, very rare in Muslim countries, right? Muslim countries don't eat pork, so it's very understandable. And here it says Saginata is not in the U.S. The FDA does do a pretty decent job about ensuring that our meat actually has no parasites for the most part. That is part of their job. So if you remember sunny pig, that'll be your Taenia solium. And if you remember angry cow or saggy cow, that'll be Taenia saginatum. Okay, so a little path. We eat the infected eggs either by undercooked beef or undercooked pork, right? Saginatum versus solium. Okay. Infected cattle, pigs. We eat that larva, contaminate food, water, or hands if we don't do hand hygiene appropriately. When we talk about the second part to solium, that one can go to any organ in your body, your muscles, your eyes, your brain. So we have to be careful on the second portion of solium, which will be the cystic circi. All right, so we ingest the stuff. It enters circulation through the gut wall, consists in the muscular tissue. So the first part of this path, only for teniasolium, okay? The first part of the path can go two different ways. It can either go into us or it can go into a pig. Okay? When it goes into us, it's accidental. When it goes into a pig, it's what it's supposed to do. Okay? Same thing with saginatum. Does the same thing if it goes into a cow. What it does, it goes into, we eat it, goes into our gut, and then it hangs out and it takes all our nutrition. But when we get to cystic circi, it'll be a slightly different issue with the path. So here, make it a little bit easier. And remember, none of these things are going to be on your test. This is just to show you what's actually occurring. All right. So you have your infected egg or your protoglid here. Okay. The red cycle is the cycle of the way it's supposed to be. Okay. So the red cycle, in this case, the pig eats it. The oncosphere goes down to his gut. It goes through his gut, and then it migrates generally to a muscle tissue of some sort. It sits in the muscle tissue, and then we eat that muscle tissue from that animal, and then we get it. Then it breaks out, goes down to our gut, and it hangs out in our gut and absorbs all our stuff. Okay? That's the way it's supposed to go. And that's generally the way it works for saginatum as well. But with cystic circi, okay, we completely lose the intermediate host. All right. We eat the infected egg or protoglid. That comes directly to us. So this first stage that's occurring here is going to occur inside of us, which means when it comes down and it goes to our gut, its first portion of its life cycle is going to go to our gut. It's going to hatch, and it's going to break through the intestinal lining, and it's going to make its way to some sort of other organ in your body. And here it's telling you it kind of likes the eyes, the brain, or muscle tissue per se. All right. Okay. So saginatum can be pretty big. On average, about 33 feet. Okay. Solium, on average, about 23 feet. Okay. You will have more than just one of these in your gut. Okay, so what do you think 23 feet of a tapeworm inside your gut's going to do?
Bloated.
Do what?
I was going to say bloated.
Bloating?
Bloating.
Oh, bloating, yes, most definitely. Right, physically, you're going to see some bloating, most definitely. But it's stealing all your nutrition. Right? So these guys have no mouth. They just absorb everything in your gut. So the bigger they are, the more they can absorb, the more surface area they have. So keep that in mind. Depending upon how many of these you have in your body is how soon or how fast you'll start developing symptoms. Or what kind of symptoms it's actually going to affect you. Okay, so here's a whole bunch of the symptoms that it can cause. Remember, initially, it's all going to be asymptomatic. In some folks, we can actually clear it. No issues, no problems, but in others, you may not. And then it's just dependent on how long it's there and how long it takes for it to start stealing enough of your nutrients for it to start causing you problems. Okay? And here, just like the other one, right? Abdominal pain, epigastric pain, malaise. The presence of the belt tapeworm causes mechanical irritation and inflammation in the intestinal linings. Right, so it'll cause some discomfort in the gut. It's just what it does. Especially when it gets too big for your gut. Right? average, if you want to compare the two, saginatum usually causes more symptoms than solium, but obviously because solium has a different process, it may actually be a little bit worse than saginatum. So, most striking feature, main symptom is passage of the portalids. Right, the active passage, meaning that it's expelled from the host body through muscular contraction, okay, versus passive, where the portalids are spontaneously detached and shed out naturally through the passage of the host stool. Right? So passive, pass it out of your standard stool. Active, the worm is actually, for lack of a better word, irritating the rectum to make those eggs go out of the system, even though you're not pooping. Okay? Now, other things to be cognizant of there, it says migrating portalids, right? So, not only is this thing gigantic in your gut, right, over time, but it's also releasing a whole bunch of portalids. Okay, those little rectangle pieces with the eggs in them. Right? Now, the opening to your gallbladder is small. The opening to your appendix is small. If this worm is extremely large, number one, it may block up those openings, causing everything to back up. So it will possibly cause you appendicitis or cholangitis. Okay? Not just the worm itself, but the portalids may also block up those areas, which means now everything is going to get backed up as well, spurring some possible cholangitis and appendicitis. So if you guys remember fever, right upper quadrant pain, and jaundice, that is what we call Charcot's triad. That'll be for cholangitis. You guys will get that when you guys start doing GI stuff. Here's some physical symptoms, right? Initially it's usually unremarkable. Usually you don't have anything until it gets really big, right? When you have that overwork burden, then you start getting some serious abdominal tenderness. You may end up having some weight loss just because you're going to stop eating because it's going to give you a sensation of fullness until you get to a point where it's absorbing enough nutrition that it's going to make you want to eat. All right? If we do go down cysticercosis, and it does make it to your brain, it will cause some neurologic abnormalities or symptoms. But when we talk about cysticerci, we'll talk about that later. Labs, what are you going to do? Stool sample. Here it says you can also do cell phone tape. I don't know if you remember that from the last time we talked. You just put some tape on the rectum and you can take a look at it, send it off to the lab. Here, you're definitely going to have eosinophilia because the size of this thing is really going to spur your body to cause some eosinophilia. Initially, it's not going to be much, but as this thing continues to grow in size and continues to affect your body, your eosinophilia will start going up. If you want to do something else, you could do antibody detection. Okay, you can do some IgG and IgM. But for all of these, if you do have PCR, you can do PCR. These are all DNA related, so you can do PCR. Right? Especially in the early signs, this thing will be very sensitive and very specific. Right? The problem is that in a lot of places where this occurs, they don't have PCR. So the simplest thing is to do an O&P, take a look at it under the scope and look for the eggs. Okay, simplest thing to do. Okay, how you can treat praziquantel. Now remember, if the thing gets too big, if it does start causing gallbladder issues, if it does start causing appendicitis, then the next possibility would be to have surgery. Okay? But that's really dependent on how the patient's presenting and the type of symptoms that they're having. Cysticercosis. All right. This is for tinea solium only. This is for tinea solium only. All right. And remember, this is when we completely cut out the intermediate host and we become the intermediate host. All right. So although it's still tinea solium, this is just a different aspect of tinea solium. This is a systemic problem, right? So if we remember, instead of it going into the pig and then going into the muscle, it's we're going to eat that egg, that infected egg, and then it's going to go down to our gut, it's going to hatch, it's going to burrow its way through the gut, and then it's going to migrate someplace in your body. This thing likes the brain, which is what we're going to talk about neurocysticercosis, and this thing likes muscle. It can go to any organ, but most common would be eyes, brain, and actual muscle, usually on your extremities or anywhere else on your body. All right. Usually you see this from folks that immigrate from endemic countries, usually from rural areas and lower socioeconomic areas. Okay? Now, the more common places that you'll see this overseas. Now, Southern California, 10% of seizures in the emergency department. Those are usually immigrants that come over here that are already affected, mostly with neurocysticercosis, because they have them in their brain. Okay, there's the path that we talked about. All right, we're generally the definitive host, not the intermediate host, but in this case, we are the intermediate host. Right, they're found in almost any tissue, skin, eye, skeletal, central nervous system, heart. Okay. They do like the central nervous system, so they do like the brain. That's why we have a specific one for neurocysticercosis versus cysticercosis. Cysticercosis just means that it went someplace other than the neurologic system. Okay. And here's a whole bunch of neurologic symptoms. The symptoms are going to be based on where the neurocysticercosis is in the brain. And depending upon where it's at in the brain is which one of these things it's going to cause. Okay, for standard cysticercosis, when it's not involving the central nervous system, it's a lot more asymptomatic. Okay, depending upon which organ it goes to. Right? If it goes to your eye, it may cause you some vision issues. Okay? If it goes to your liver, it may cause you some liver issues. Most of the time, it likes to go to your muscles or your extremities. Okay? When they're in the muscles of your extremities, it doesn't really cause too much of an issue symptomatically. But when you do get quite a bit of them in your muscles, it may cause pseudohypertrophy, making your muscles look bigger, even though they're really not. Okay, so here's some physical signs. Okay, it's really not affecting anything, so you're not going to have a real fever. Okay, non-neurologic findings, papilledema, and then just right, depending upon where it's actually affecting you, there's some of those physical symptoms that you're actually going to get. And there at the bottom is your muscular pseudohypertrophy. Here in a bit, I'll show you an X-ray with a whole bunch of cysticercosis, which will kind of demonstrate why you end up with pseudohypertrophy of the muscles. So, the top part there, CT, MRI, ELISA, CBC, CSF, eosinophilia, or just CSF, is more so for the neurologic aspect of cysticercosis. Preferably, you can do a CT. It's a lot faster. It's a lot cheaper. But if you do want to see the specific type of scolex that this thing does have, you want clearer pictures, then you can do an MRI. But CT is good enough because it will tell you what you need to know. All right. You're going to get eosinophilia because the thing is migrated through your entire body. So as it migrates through your body realizes there's a foreign substance there, a parasite, and eosinophilia is what usually you let off to go get that. Now, what you need to remember with cysticerci or neurocysticerci, this aspect of the disease process, you are not going to have positive stool sampling, right? When we're the intermediate host, this thing goes, hatches in our gut, and then migrates to a body cell. Once it migrates to a different body organ or muscle, the only thing it does is it encapsulates itself and it just hangs out there. Okay? It's waiting for the next stage of life for it to go forward. And it's not going to go forward because nobody's going to eat us, right? We're top predator. Right? So it's just going to sit there. Right? So we're never going to find any eggs pooping out in our stool for this. So when it's in our muscles, on the other hand, we can just biopsy that, send it off to the lab, and the lab will tell you what that is. So that's it. Okay. If you look at those little bumps up top, okay, here's some neurocysticerci up here in the anterior portion of the brain. All these little black spots, it's all neurocerci in the brain. Right? And as you said, depending upon which portion of the brain is actually affected is what kind of symptoms you're actually going to have. This is a post-mortem brain, and you can see all the neurocerci that this person actually had in their brain. Same here, down here, all these things. Should not be all these holes in the brain. All right, so when it embeds into your muscle, right? This is generally what it looks like, right? It looks like a little lump, subcute nodule, right? But after a day, just one day, treatment-wise, it's almost gone. You made treatment praziquantel. And here on X-ray, you can still see some fuzziness, but basically gone. Now, if you see all these little white rice grain-looking things here, these are all cysticerci embedded into the muscle. All right. It's even worse on this one, where you can see it. Okay, which is why it causes your muscle to pseudo-hypertrophy and make it look like it's bigger, but in all reality, it's infested. Is what it is. Okay. Here's one in the eye. Okay, so it may cause you some visual changes. All right. Treatment, supportive care. Right? Be prepared to take care of any kind of seizure activity if it is in the brain. Okay? Oxygen, anticonvulsants for the seizures. Okay? If it does cause intracranial pressure, you can do osmotic agents, steroids to decrease some of the inflammatory process, which is kind of questionable, depends on who you're talking to. Try to use diuretics, most definitely talk to an IV specialist. Right? Those guys will take care of it. Okay, symptomatic care. If you do need to do surgical treatment, removal of cysts are possible, depending upon where you find them. Right? The problem with this is that it's really complex and highly individualized when you're going to take care of somebody with neurocysticerci. Okay. The number, the location, the viability, are they alive or dead? Right? The inflammatory state of the cysts. There's a lot of things to take into account when you're going to take care of this patient. Right? Because the main goal of this is basically to get rid of the cyst, right? To kill the parasite. Okay. But because it's in the brain, you have to be even more careful. All right? So the death of this parasite will cause overinflammation and edema of the brain. Because as the parasite dies, it releases toxins. As those parasites die, the body wants to go and take care of it. As the body goes and fights, takes care of it, it causes hyperinflammation. Right? Remember, when we get hyperinflammation, everything swells up, right? Your brain's in a dome. Okay? You can't go any further than your skull. So it's going to have intracranial pressure, so you have to be careful, which is why a lot of folks like to add that dexamethasone on top of treatment. Now, albendazole is the main source, and it'll be albendazole and doxamethasone. That's what you're going to treat with. Again, lots of ands, ifs, or buts. But usually it'll be albendazole and dexamethasone. But in some cases, it'll be albendazole, praziquantel, and dexamethasone. Those are rarer cases, but again, the ID specialists will probably be making those calls. Okay? But if you are going to treat, the treatment will be albendazole and dexamethasone. For neurologic sister circi. Big thing is to make sure that you treat symptomatically, because you are going to have increased intracranial pressure due to all the inflammatory processes and toxin releases. All right. Diphyllobothriasis, okay, aka fish tapeworm. Okay. Fish tapeworm. Different than the other tapeworms that we've talked about, yes? Okay. Most of you guys usually always get this one right. So it's still completely weird, different than the other ones. Deals with lakes and rivers, freshwater fish only. Freshwater fish only. Freshwater fish only. Okay. Here it says Northern Hemisphere, Europe, former Soviet Union, North America, Asia, Uganda, Chile. Remember, if we are fishing nowadays from these places, we can have this fish on the other side of the world in less than 24 hours. Right? So, understanding where some of the foods that we eat come from can also give us clues as to the possibility of what's going on in the patients. So, a whole bunch of different places, but remember, consumption of raw or uncooked fish, freshwater fish specifically. All right. So here, a little bit different. Contaminated eggs are discharged into water, right? Goes into the environment. Some crustacean eats it, hatches out into larvae. Some fish eats that fish, or some fish eats that larvae. And then some predator fish eats that other little fish that ate that larvae, and then we catch that fish, and then we eat that fish, and then we eat that fish. Usually the way it works. Okay. Then this guy likes to hang out into your intestinal system, and he just attaches on there and sucks all the nutrients out of your body. Okay. That's what it does. And there it's telling you 1 million eggs per day per worm once it fully matures. It usually takes about 2 to 3 months to fully mature inside your gut. Okay? And they can live up to 10 years in there. Right? Great. So remember, we are not the only definitive host for this. Any animal that eats fish can be a definitive host. Right? Bears, seals, dogs, okay? People are usually the ones that get infected. Birds, but it usually likes the jejunum and the ileum portion of the small intestine. All right, so remember, these are not going to be on the test. But if you look at the head on this one, right, look at this, what we call a rothria. They're not suckers, they're not hooks, but it's like a weird mouth, and that's what they use to attach to your intestinal lining. Okay? That's what they suck the blood out. Right, so some infected person, animal, poops in the water, little water, it ends up hatching, okay? Some little fish eats it, some big fish eats it. We capture big fish and then we eat it and we get it. Okay? Real simple like that. Alright? This is generally what it looks like. This thing can grow up to 82 feet, 85 feet long inside your gut. Okay? And it steals all your nutrients. Right? That's how it survives. Okay? So initially you're going to be asymptomatic, right? Until you start getting that overworm burden, right? When it gets too big or you get too many. Okay? What I'd like you to remember, here's a whole bunch of signs and symptoms. Flushy, fatigue, diarrhea, dizziness, weakness, numbness of extremities, sensation of hunger, pruritus. Do you know what vitamin causes numbness of extremities? Which one? Vitamin B12. Okay. So what I want you to remember for this, and I'll probably do the next slide, I think. It takes all your vitamin B12. Okay? What I want you to remember for this, it takes all your vitamin B12. Lack of vitamin B12 also leads you to megaloblastic anemia. Okay? Megaloblastic anemia will also lead you to some of these symptoms that you see here. Fatigue, diarrhea, dizziness, weakness, and extremity sensation of hunger. The sensation of hunger is because it's stealing all your nutrients, particularly your vitamin B12, which also affects your folate. And folate helps build some of those eosinophilia out of your bone marrow. Okay. And just like the other ones, it'll cause some pruritus, right? The little eggs are going to be released, and it's going to cause some rectal itching. Right? But just remember, big key here. You've got a whole bunch of symptoms, but your big key there is it's got an affinity for vitamin B12. Okay? It likes to take a lot of vitamin B12. And there, 40% have decreased vitamin B12 levels, so you can also check for vitamin B12 in these patients. And the jejunum is one of the preferred places this little guy likes to hang out. And in the jejunum is where we usually absorb most of our vitamin B12, which is partially responsible as to why he likes to hang out there. Right? Okay. As we mentioned, chronic deficiency of vitamin B12 can lead to megaloblastic anemia, which will lead to abnormally large or immature red blood cells. Then it could lead to the fatigue and weakness and dizziness and numbness. Okay. So here's some of the physical symptoms that you'll have. Pallid, right? You look a little bit pale, sucking out your stuff. Glossitis, usually with loss of B12. Your tongue will be a little bit more inflamed. Dyspnea, tachycardia, weakness, and prestige. Right? So you'll have quite a few different symptoms there to look at. Labs, you can do an O&P, you can do a CBC, because that's going to tell you whether you have the anemias or not. Okay. Hemoglobin hematocrit may be low because it's sucking on some of your blood, part of what it does. Okay. The eosinophilia will be there. Your vitamin B12 may be low, and you can also check the folate. Those two usually go hand in hand. It's really important for the maturity of the red blood cell, especially in creating them in the bone marrow. Okay. So treatment, vitamin supplementation, B12, right? If it's really bad, folate, if it's really bad, and prosoquantal. So far we've only had two meds, right? Albendazole and prosoquantal. So pretty good so far, no issues? Yeah? Okay. Alright. Anybody have any questions? No? Alright, let's take a break. Okay, the next set of worms we're going to talk about will be the trematodes. Those are aka flukes or flatworms is what we generally call them. Okay, these are the ones that we're going to talk about. What I'd like you to remember for blood flukes, for the hematobium, japonicum, and mansoni, is that they have specific places in the body that they like to hang out. Okay? And that'll give you a determination of how to find them. Okay? Liver flukes, hepatica, right, liver, so you know where that guy hangs out at, liver. And then your pericarditis, Westermanni, lung fluke, that hangs out in the lung. Okay. So any numerous flatworms of the class Trichoda. They're parasitic flatworms that affect blood vessels, gastrointestinal tract, liver, lungs, quite a few different places. They kind of have a complex life cycle. They usually require at least 2 hosts, which means outside the body they'll go infect something. Most common is a snail of some sort, and then eventually we'll end up eating that, which is how we end up getting it. Okay. So when diagnosing these guys, probably should look at what part of the world you're in. Okay. As we mentioned, ID is really where you're at. Okay. The vector, okay, what caused this? Okay. Did you eat anything crazy? Okay. Particularly for these guys, because these guys have more than one intermediate host. So snails, depending upon which one it is, if you eat them, can be a way to spread them. But usually any aquatic or semi-aquatic animal can be that secondary host, right? So it'll be a fish, it'll be a snail, and it'll be a fish, and then it'll get to us. Okay? Or any other vertebrate that eats those types of foods. Right, so eosinophilia is not associated with protozoa. That will be usually regular labs, stool OMPs, depending upon where they're at. The trematodes, they have to migrate to get to where they're going. During their migration phase is usually when we have a lot of eosinophilia. Okay. Prior to that, we usually don't, or it's very mild. So we kind of have to be careful exactly when we catch it. If we catch it too early, you may not get any. If we catch it too late, you may not get any eosinophilia. But it usually occurs during the migratory phase. When it's just hanging out in the intestinal tract, we're not going to have any eosinophilia. Okay? And this thing causes the same thing as the other ones. As far as the response, it triggers the T helper 2 cells, creates an immune response, which commonly calls in interleukin 4, 5, and 13. So no difference in any of the other ones that we've talked about so far. Schistosomiasis, this is a big one. Okay, there's 3 right there. Hematobium lives in the vesical plexus. Alright, vesical plexus is the bladder area. Okay, the other 2, superior and inferior mesenteric veins, live in the intestinal vessels that lead to the portal vein that can lead to the liver. Alright, so there's places that these guys are going to live. This is one of the most important trematode infections that we have, because soma is the only trematode. This is the only one, okay, that invades through the skin. So when you go in the water, it gets out to your skin, and that's how it penetrates into your body. Okay, this is the only one that does that. On average, about 2 million people worldwide are usually affected by these things. And we said hematobium Usually is in the vessels that drain the bladder, so it's connected to the bladder. Jepinovcum is associated with splenic vein that forms that portal vessel, that portal vein, and Manzoni is blood draining from the large intestine that connects to the portal vein as well. Okay, these guys are very specific as well because they actually have male and female schistosomes. And the other trematodes are usually hermaphroditic. They can reproduce on their own. That's why they can produce those protoglids, right? The eggs inside those little rectangle things. They can do it on their own without anything else. These guys, on the other hand, have male and female type species. So they are a bit different in that manner. There's 5 different schistosomal species, but only 3 of them are the ones that we're going to really talk about. Okay? Now look at the location. Teratobium is Africa, Middle East. Porphyrium is in Far East, and Manzoni is in South America, Caribbean, Africa, and the Middle East. Okay. Here's your distribution for Teratobium. Here's your distribution for Manzoni. So Manzoni, right, has enteric vein, right, that can cause liver and spleen enlargement because it can back things up, which is one of the presentations of Manzoni right here, okay? Causing ascites in the belly. This is the distribution of Jepinovcum. Do you think Japan is infected with this? Say again? They don't really, yes. So Japan, number one, is not infected anymore, but when they found this in Japan. Japan has completely eradicated this in the country. Okay? But because of where it was found is why it's called that. So if you look at that distribution upper right corner there, Japan is not infected. Okay? So here's your life cycles, right? And it's excreted by generally us or whomever is infected, right? Remember, if you're going to look for hematobium, because it is associated with the bladder, you're going to do a urine sample, right? It's associated with the bladder, so if it's pushing out eggs, it is going to push out eggs in the urine. Vice the other 2, which are associated with the intestinal tract. When they push out their eggs, it's going to be the stool. So when you look for hematobium, it'll be in the urine, and when you look for Jepinovcum and Manzoni, it'll be in the feces. There has been some implication with hematobium and cancer, bladder cancer, which is very rare, okay? But not definitive just yet. All right. So the infected egg goes into the water, the little thing hatches, it goes into a snail, goes through cycles in the snail depending upon which one it is, it comes out, fish eats it, then another fish eats it, and then we eat the fish. Right? Well, take that back. It hatches through the snail, it gets released into the water, we go in the water, and then it kind of clings onto us. It loses its tail and it gets absorbed to our skin. Okay? That's how they get into our system. Once they get into our skin, they penetrate our skin, and then they migrate through the skin to the muscles, to the area that they're looking for. Okay? Remember, each one of these things like their little areas to hang out in. Okay? And remember, during that migratory phase, once we penetrate the skin, we'll start having that eosinophil, right? Okay. So here's the right, you got your contaminated eggs in the water, they hatch, they go into a snail, they probe. do whatever they want to do inside those snails. They come back out. This is what it looks like when it's in the water. They're microns in size, so you really can't see them. This little top part here will go ahead and attach to your skin. This tail falls off, and just this little area right here is what gets penetrated into your skin. Okay. And then it penetrates your skin, it goes through the circulation until it finally finds migration to the portal or liver or maturation, where it maturates, hatches, and does whatever it's going to do. Okay? So remember, each one likes to hang out in different places, right? So acute schistomiasis. Catamol fever is basically a systematic hypersensitive reaction that occurs with the onset of the egg laying of the schistosomes in the body. And it's just a reaction that your body is noticing. Okay, there's your signs: fever, cough, abdominal pain, diarrhea, splenomegaly, okay, which is one of the things that we saw in that last picture there, and eosinophilia. Okay. More so for Manzoni and Jagger. Just because they're the ones that hang out in the GI tract, right? Not the urinary tract. Now, serum sickness is an immune complex mediated hypersensitivity reaction that classically presents with fever and rash. It's kind of very similar to Katayama's fever. Okay? So you have to be careful in denoting the difference. Okay, so what are you going to do? Do store urine microscopic identification. So, like most of the other ones, you've got to do this multiple times. Most textbooks usually say 2 to 3 times, because it's really dependent on when these things kind of lay eggs, that you may or may not see those eggs in the urine or in the stool. Okay. So make sure you repeat them on several different days. Okay. That is the most common and easiest way to do it. Can you do a PCR for this? Yes, you can do a PCR for this. But understand, the locations where this occurs, most of the time they don't have PCR capability. So microscopic identification is the best way to do it. Here it's telling me that between noon and 3 p.m. is the most common time to do the urine sample, where you may find eggs. Okay. And then you can do antibody detection as well. You can do ELISA or IFA if you like. Your choice. So what's treatment? Protocol. Pretty good, right? Alright, so just like all the other ones, okay, make sure you follow up in 1 to 2 months. Make sure you do another exam and make sure that all those eggs are dead. Okay? Because if they're not, then you're going to have to treat again. Okay? Just for verification's sake. And for none of these things do we have a vaccine. Alright? Fascioliasis. That's your liver fluke, right? That's your hepatica, liver, sheep liver fluke, occurs worldwide. There's 2 different species there. They're also found in raw and undercooked fish and mature and wild ducks. Okay, everyone likes a home. His home is a wild ducks. All right. This thing is more common usually where you see sheep and cattle raised. Here in the U.S., we don't usually have that problem because our animals are well taken care of. Right? Now, the biggest thing to remember with this one is that very bottom line there where it says humans consume raw watercress, Europe, Middle East, and Asia. Watercress is a green leafy vegetable. Okay? This parasite swims around and ends up going onto the watercress, and usually we end up eating the watercress, and that's how we end up getting it. Same deal with the animals. The animals end up eating the watercress, and that's how they end up eating and getting it. Okay? Okay, the immature eggs discharge in the biliary duct. Undergo several developmental stages outside the body. Usually through snails, and then they're released into the water. Either the animals drink the water, or parasite goes onto the watercress, which is the most common, and then we ingest it, gets into our intestinal tract, breaks through our intestinal tract, and migrates its way up to the biliary ducts. Okay? And remember, during that migratory phase, when it breaks through our intestinal tract, is when that eosinophilia is going to kick in. Okay? Not when it's just hanging out of the intestinal wall. And these guys can grow up to 30 millimeters, okay, which is a little over an inch. Here's your cycle, right? So some infected egg goes in the water, kind of matures in the water, gets in the snail, right? It goes through a couple of developmental stages here in the snail. Then it gets released out into the water again, and then it either hangs out here, or these little guys drink the nasty water, or eat this, or we eat this, and then we get it. Pretty simple message. Okay. So here for the acute phase, migration will last for months. Okay. Abdominal pain, abdominal fever, vomiting, diarrhea, urticaria, eosinophilia. Abdominal pain is probably for the migration and inflammation of the liver and for the bile ducts. Hepatomegaly because it's blocking it up, right? Inflammation of tissue damage, right? Caused by the parasite because of the migration. Okay? That fever may result from the migration of that parasite into the body. Okay? Irritation of the gastrointestinal tract and bile duct possibly cause that vomiting. Irritation of the bile, irritation or blocking of the bile flow can cause some of that diarrhea. And urticaria is just the allergic reaction to the parasites, antigen, and it migrates. As it's migrating, you're going to end up with eosinophilia. That chronic phase there, it may look like biliary obstruction. So it may look like a gallbladder problem. So studies to determine whether it is or not a gallbladder problem. On average, these guys usually lay about 20 to 25 eggs per day, 1,000 eggs per day. And these guys are a little, well, not a little different. These guys are a little bit more different because their intermittent stages of laying eggs are a little bit broader than some of the other guys. So it takes them a little bit longer to drop eggs. The only thing I need you to know on this slide is that folks from Vietnam, serving in Southeast Asia, they have found in the VA a correlation of cholangiocarcinoma because on average, what do these guys like to live? In bile duct, right? So they found that association causing these guys cholangiocarcinoma. That's really what I need you to know from this slide. Okay, so test and diagnosis procedures, identification of the egg. Right? It's going to poop out those eggs into the small intestines from the bile duct. It's going to go out and then poop them out. You can do an antibody detection or ELISA if you like, your choice. You can do a PCR if you like, your choice. But remember, when you're looking for these eggs, you're still going to have to do 2 to 3 samples because in this case maybe a little bit more depending upon how intermittent they are laying their eggs, if this is what your thought process is. And then how are you going to treat trachlobenzazole? Okay, so this one's a little bit different than the other ones that we talked about, right? Okay. Diagnosis. Paragnomyosis, lump. about 10 different species. We're not gonna mess with all of them. Most common is Western Maine. And humans are usually infected by eating raw, pickled, or poorly cooked freshwater crustaceans. Okay. Do we have freshwater crustaceans here in the U.S.? We love to crawfish. Okay. Crawfish boils are a possibility, right? Where do those usually happen in the U.S.? Usually in the southeast, right? Sometimes in the Midwest, right along the Mississippi. So, because we already know that, when we talk about the U.S., that's the most common areas that this stuff happens. Right? Isn't science wonderful? All right. So we have other species and other places that this stuff occurs. Asia, Americas, and Africa. When they say Americas, North America, Central America, and South America. Okay? All those places have this problem. And it's usually consumption of freshwater crustaceans that contaminate the larvae in most of these. Okay. Life cycle. Infected person, right, can either spit it out or poop it out. Okay? Then it goes into the water, then it develops into its little life cycle, then it goes into a snail of some sort, then it develops inside the snail, and then it releases from the snail, and something eats it, crustacean-wise, and the crustacean's infected, and then we catch that crustacean, and then we eat it, and then we eat it. That's usually how it works. Okay? Once we ingest it, this one's a little bit different. Once we ingest it, it goes down to the duodenum. Right? It breaks through the intestinal wall, and it migrates through the diaphragm up into the lungs. And once it gets into the lungs, then it starts causing us problems. Okay? So remember, this one breaks out of our intestinal tract, it goes up into it, migrates up into the lungs. And during that migratory phase is when your eosinophilia will be kicking in. Okay? And here it tells you 7.5 to 12 millimeters, like 4 to 6 millimeters. That's like 0.3 inches, 0.5 inches or so. Okay? Now, here it says eggs are ejected in sputum. So remember, once it gets into your lungs, I can spit it out. Right? So that's why we can find it in a sputum. The other thing that occurs, this thing will stimulate your coughing reflex because it's trying to survive and procreate, so it wants those eggs to come out. So it'll stimulate that coughing reflex. It'll help make you cough it out, or it'll get you into your mouth so that you can swallow it. Goes back down to your intestinal tract, breaks through your intestinal tract, and starts going back up into your lungs, and you start getting them. Okay? These guys aren't dumb. None of these are dumb. Okay? These guys are pretty smart about the things that they make us do. Here's your life cycle, right? Where usually the infected host, here's the poop in the water, the egg, as it matures, ends up going into a snail, goes through more life cycles within the snail, gets released, some crustacean eats it, we end up eating crustacean, and then it goes into our gut, it breaks through the gut, and it migrates to the lungs. That's what it likes to do. Try to keep it simple, try to keep it basic. Okay? This is what we just finished talking about. We do have these crawfish deals here in the U.S. So, right, along the Mississippi River, down in the southeast, Louisiana, right, we have a whole bunch of these. So, on average, this is generally where we see these things at. Now, Western Maine is usually overseas. kellicoti. P. kellicoti is a species that we have here in the U.S. So if you're looking for something, P. kellicoti would be the ones that you would find mostly in Mississippi and Louisiana areas for the U.S. Those kind of crosser spoilers and stuff like that. So here's some symptoms. Okay, we'll have an acute phase and a chronic phase. Right? The acute phase is mostly making its way up into the lungs. Right? This is the migratory phase. Okay, this is where the worm can trigger a range of symptoms due to inflammation and tissue damage that it's causing as it's making its way up to the lungs. Right? Because it's breaking through your intestinal wall. It's breaking through your diaphragm. It's breaking through your external aspect of your lung tissue to burrow its way into your lungs. So it's causing quite a bit of damage. So it's causing a lot of inflammation and tissue damage as it's breaking its way up there. On average, it takes anywhere between 2 to 8 weeks for this to happen. Okay? After you kind of ingest that contaminated crawfish. And it takes them a while to mature too, so you may not really get anything for maybe 2 or 3 months for them to start producing eggs. Okay. So invasion migration is usually what's occurring, and we talked about a lot of these early. Usually you don't get caught in the acute phase unless they make it into your lungs pretty quickly. You'll have urticaria because your body can react to this, especially during the migratory phase. The hepatosplenic membrane, depending on the route that it takes to get there. Okay. You'll start having some pulmonary abnormalities once it makes it into the lung. Okay. And then during that migratory phase is when you're going to have eosinophilia. But over here, when you get to the chronic phase, it almost seems like it's TB when you look at some of the symptoms. But if you do the chest x-ray, it's definitely not going to look like TB. There are so many variances of how this thing can present on chest x-ray that we don't use chest x-ray as a definitive means of diagnosis because it can show up in a whole bunch of different ways. But what it does do is it does stimulate that cough reflex, right? And spit out that sputum. You may have slightly discolored sputum as it's breaking through the tissue of your lungs. Obviously, it's hitting some of the vessels. Right? Once it's in your lung, it'll start eating away at some of the tissues, which may cause some leakage of vessels into your lungs as well, which is where you may end up with some hemoptysis or discolored sputum. Well, this thing does do a bunch of different things. It's worse off in the chronic phase and in the acute phase. Okay. So diagnosis, demonstration of eggs in stool or sputum. Here it says presents 2 to 3 months after infection. Right? That's about the amount of time that it takes for it to get there and appropriate. Just remember, you might have to do multiple samples. Right. And then you have a couple of other choices there. You can do biopsies if you like. Not too many folks do that. You can do a PCR here as well. And there it tells you your chest x-rays are not diagnostic. But I think it's just too much. Too many different presentations. They can show shadowing, annular rings, cavitations, liver opacities. They can look like lung abscesses. They can look like a whole bunch of different things. So chest x-ray, not the best. Okay, this one's not a great x-ray, but if you do look here at the positive arrow signs, you can see some little masses right there. Okay. Treatment, tricol, benzol. I would also write here praziquantel. Okay, I'll also write praziquantel. Given a choice, praziquantel would probably be better. They just made cyclobenzazole more of an off-label use for this, so praziquantel would probably be a better choice. Okay. Anybody have any questions? Yes, no, maybe. I want to do the very first one for the next block. For nematodes. We'll do strongly oily using them. We'll call it like that. Okay. So here's a whole bunch of worms. You have the intestinal nematodes, and you have your extra intestinal nematodes. All right. Well, the first one's generally like to live inside your intestine, right? And the other ones are really will be outside. Okay, real simple. Okay, these guys are unsegmented worms. Okay, remember, you guys have a mouth, a gut, and an anus. Ascaris is one of the biggest worms that you'll probably see, intestinal worms that you'll probably see. These worms can reside anywhere in the GI tract, blood, lymphatic system, subcutaneous tissue. So you may see them in quite a few different places. Okay, that Ascaris is a giant round worm. Let me see if I can find a video, or I'll see if they'll let me play the video of the Ascaris being removed. Strongyloides is one of the major soil-transmitting parasitic diseases. They estimate up to 100 million people worldwide are infected with this thing. It's called Strongyloides stercoralis. Tropical and subtropical areas. Tropical and subtropical areas. Remember, an ID is extremely important where you are to get some of these things. For this, it's most common in southern United States. And it's one of the major soil-transmitted parasitic diseases found in soil or feces. Found in soil or feces. A lot of reasons why this is found in more so the southern aspect of the U.S. is because it is more rural and they have a lot lower socioeconomic groups down there. And those are the groups that are most common for this. And it's usually when bare skin is exposed to the infected larvae in the infected soil or feces is how it penetrates your skin. All right. Here's your life cycle. Okay. The larvae soil penetrates bare feet. It travels up to the lung, okay, so it migrates through your body, right, all the way from your feet up to your lungs. It makes you cough, and then you swallow it. Then it goes down to your intestinal tract, usually lives in the mucosa, submucosa of your duodenum or jejunum, where it likes to hang out. Starts laying eggs. Just like some of the other ones, you can cause auto-infection to yourself if you don't have good hygiene. If you do continue to auto-infect yourself, you can have this for decades if you continue to auto-infect yourself. continue to auto-infect yourself, your worm burden can increase dramatically. Here's your life cycle. Okay. Here's the worm. Okay. Going on this way, natural. Okay. This is all natural outside in the environment. And then this is if it's already developed and we walk in. Okay. Here it's telling you that dogs may also serve as definitive hosts. And once it penetrates our skin, it makes its way up to the lungs. Once it's in the lungs, we swallow it, and it goes down into the intestinal tract, small intestine specifically. It deposits eggs and we poop them out. And it continues to eat all our nutrition as we eat. Okay. We'll end up with some gastrointestinal symptoms, abdominal pain, diarrhea. Loeffler syndrome is when eosinophils accumulate in the lungs in response to the parasitic infection higher than normal levels. For example, eosinophilic pneumonia. So you have so much that the inflammatory process is making it difficult, causing you coughing and wheezing. Urticarial rash, similar strain reason. Okay, but especially in Asia, farming barefoot, contaminated soil. Here's some extra risk factors. If you have diabetes, HIV, cancer, or transplant steroids, those are folks that are more at risk for stromal use. If you are immunocompromised, okay, it can cause meningitis or sepsis. Those guys are also at high risk, and there's not much fight that your immune system puts up against this stuff. All right. And here it's telling you eosinophilia in acute and dissemination stages, but absent when it's in the chronic, right? Because when it's in the chronic stage, it's already just hanging out in your intestinal tract. If it's just hanging in your intestinal tract, then generally you're not going to get too much eosinophilia unless you end up with an overwhelming burden. Test diagnostic procedures, right? Stool OP. Right? If you want to be a high-speed guy, you can go in there and try to do duodenal fluids. Usually doctors will do that because you want to sedate the person when you're doing that. Here you can do the internal string test. Okay? And then you can do the ELISA testing if you want. If you do have PCR, by all means, use PCR. All right. That is one of the best ways to do it, if available. Okay. And then treatment, ivermectin or albendazole. So now we're starting to go into different types of treatment and different types of meds. All right. Questions? All right, you guys want to stop here? Or you guys want to go on? Okay. We'll continue this